Assalamu alaikum everyone. I hope you are all doing well. My name is Sana Suhail and I am delighted to welcome you to tonight's Pharmacozyme official webinar, a platform where we bring pharmacy professionals, students and thought leaders together to grow and learn. Tonight's topic is clinical pharmacy and its approach in patient appointments, an area that is gaining immense importance as pharmacists continue to evolve into key healthcare providers. I am incredibly honored to introduce our esteemed speaker, Ms. ARZU MOOSVI, a dedicated clinical pharmacist, founder of MedMadad, and a true global pharmacy enthusiast. Her work in patient care and advocacy for clinical pharmacy has inspired many, and we are excited to learn from her expertise this evening. Before we begin, here are some instructions for participants. The webinar is being streamed live on our official Pharmacozyme channel. Feel free to drop your questions in the chat box throughout the session. We will have a question answer session at the end, so stick around for that. The top 10 scorers in the quiz will receive a certificate of excellence from Pharmacozyme. Without further wait, let's warmly welcome Ms. ARZU MOOSVI to share her insights on how clinical pharmacy can shape more effective and patient-centered appointments. Over to you, Ms. ARZU.
Thank you, Sana, for the great introduction. I have no idea how many people are on here, but good to have everyone on. So just as a reintroduction, my name is ARZU, and I am a clinical pharmacist with Health. Let me actually go to the next slide. Okay, so I'm a clinical pharmacist with Health, and I am located in Los Angeles, California. I'm the founder of MedMadad, which is currently in renovation in Sucker. And this is actually based off of clinical pharmacy. And so I'm hoping that it will be a very good outcome. And I have no financial disclosures to make at this time. Okay. All right, so let's get into it. So today's learning objectives are to define clinical pharmacy and distinguish it from traditional pharmacy practice. So oftentimes you see in community settings, like if you go to a medical supply store or a pharmacy, that you're just being dispensed medication, but you're unsure if this person is a pharmacist, for example. So we'll be distinguishing clinical pharmacy from your traditional old route. And we will describe the roles and responsibilities of a clinical pharmacist. We will apply clinical pharmacy methods to a patient case, and then we will identify barriers to clinical pharmacy in global settings. All right, so we'll start off with a background. And so what actually is clinical pharmacy? So clinical pharmacy is a practice of optimizing medications to improve patient health outcomes. And that sounds like a bunch of words, but we went to school for 4 years or 6 years. I'm not sure in Pakistan how many years, but here in the US, we do 4 years of our bachelor's and 4 years of pharmacy. And so, we spend 8 years in total learning on the science background and then how to manage medications and the clinical aspect of it. And so that's ultimately what we're trying to do in clinical pharmacy, is to optimize these medications that we learned for so long about. It is a focus on patient-centered care. It consists of medication reconciliation, interpreting lab values, adjusting medications according to lab values, adjusting medications according to side effects, and utilizing evidence-based material for guidance. It's imperative that we also stay up to date on guidelines as well when we're looking into clinical pharmacy. So I'll kind of get more into this, and we'll go into a patient case that will help. So we'll get into the statistics of why clinical pharmacy is so important. In 2019, clinical pharmacy practices were actually proven to reduce medication errors and adverse drug reactions by 30 to 70%. And these statistics are actually based from the US. They are not a global application. So I wanted to just let you know that. Medication adherence has been proven to be improved by 15% to 25% in pharmacist-led interventions. So medication adherence is when the patient is taking their medications as prescribed, right? And so that's the base of a pharmacist is, are we making sure that our patients are taking their medications how they should? And so there was a research done and they showed that when pharmacists are involved in patient-centered care, there is about 15 to 25% reduction of, or improvement, of medication adherence. Pharmacists have proven to help decrease systolic blood pressure by 7 to 12 millimeters of mercury and A1C by 0.5% to 1.5%. This statistics was also found in 2019. Every $1 US that was spent on clinical pharmacy services resulted in 4 to 12 US healthcare savings due to reduced hospitalizations, ER visits, and any other complications. So as you can see, pharmacists who are involved in clinical pharmacy practice are oftentimes helping to enhance the longevity of a patient. So what are the goals of clinical pharmacy? So the goals of clinical pharmacy are to improve therapeutic outcomes, reduce medication errors and adverse drug reactions, promote rational use of medications, and enhance patient quality of life. Oftentimes, doctor appointments are limited due to lack of availability of specialists, short appointment slots, excuse me, and medical deserts. Excuse me. So the availability of specialists can be very limited. So that depends on if a doctor is specializing in a specific route, correct? And so when they specialize, how many of them are there in a certain area? And are there enough PCPs, for example, or what we call in the US as primary care providers? And so we have to kind of look at, is there an availability of primary care providers? So family medicine doctors, what's the availability of the specialists in a certain area? So we're looking at geographic location. We're also looking at the short appointment slots because oftentimes, maybe you've noticed that when you go to the doctor, sometimes they don't have enough time to actually give you time, I guess. So sometimes they have 15 minutes, they have 20 minutes, but they can't address everything in the appointment. And so this is kind of where pharmacists can come into play with those patients who are on a lot of medications. What we call medical deserts here in the US, and I think this is very common globally as well, is that medical deserts consist of areas in certain countries, and I would say majority of countries always have medical deserts. And that means that there's not enough accessibility to any kind of medical care access. So if you're in a rural area, then oftentimes you see that the next clinic might be about an hour away. And that hour might be because of the way that the road is, the way that the actual location of the place. So there are a lot of factors that go into medical deserts. While there is a reduced number of pharmacists compared to medical doctors throughout the world, it is imperative to utilize our skill set to maximize the threshold to mitigate healthcare gaps. And oftentimes you'll see that the healthcare gaps that exist all throughout the world, whether it's the US, whether it's Pakistan or anywhere else, it's in part to do with not leveraging the pharmacists that are there, not leveraging other healthcare professionals that have been taught material that they specialize in to actually apply it. So I come in and out of Pakistan frequently, and I notice that pharmacists are usually in the industrial setting. And so, if I'm not mistaken, in industrial settings, you often don't see clinical application. And so, what happens is that gets lost in the workflow of healthcare. And so, if we maximize if we maximize pharmacists to come into the workflow of patient-centered care, you can reduce so many different factors like medication adherence, clearing people's medications up, optimizing their doses, optimizing the frequency. So the areas of practice in the US where clinical pharmacists can practice are often in inpatient settings, such as hospitals, outpatient ambulatory care clinic, which is actually where I work. So I work in an outpatient setting. And then specialty clinics such as oncology, cardiology, infectious diseases. You can also see them in community practice. I'm sure you've heard of maybe CVS or Walgreens. Sometimes they have pharmacists who work on medication therapy management. And so that's kind of what we look at when we think of community practice and clinical pharmacy. You might also see them in long-term care facilities where those who are above a certain age, who are not able to take care of themselves, there are facilities for that in the US. And so you'll see clinical pharmacists practice there as well. Most US states require what we call a collaborative practice agreement, which is called a CPA. And it actually allows pharmacists to work with providers to manage chronic conditions or needs such as birth control or pre-exposure prophylaxis for HIV. So usually in a collaborative practice agreement, a lot of pharmacists work for chronic medical conditions like hypertension, hyperlipidemia, and diabetes. So those are the main three that a lot of pharmacists work on. And then you have additional things such as anticoagulation or pre-exposure prophylaxis for HIV. And then some pharmacists actually practice to help provide birth control as well. Now, to give you context, a collaborative practice agreement is specific to each state. So it's actually specified under a particular law. So pharmacy law in the US is really, really important. And you have to go according to the state. So California might be different than Virginia, or Virginia might be different from Washington, DC. So it's very imperative over here to know the law to understand what you can practice in a clinical setting for pharmacists. So I'll kind of touch on the very base of clinical pharmacy. I think, and this is kind of more of an opinion, but also factual. So the base of clinical pharmacy begins with medication reconciliation. And the reason I say that is because in an outpatient setting, you will see a lot of patients who are on multiple medications, especially those who are, above a certain age. So maybe 60 and above. Frequently, they have, different conditions that go hand in hand. So if they have hypertension, if they have hyperlipidemia, or diabetes. And so this is the base of where you want to start with clinical pharmacy. So what medication reconciliation actually is that it's just a medication review. And what it does is that those who have multiple medications oftentimes are seen by multiple specialists. They've recently been discharged from the hospital, or they actually doctor hop. And what that means is they will see one family physician, and then they will stop going to that one, and then they will go to another one. And so what we look at with medication reconciliation is how can we streamline their medications so that it is consistent. And that can be really hard when these patients are seeing different specialists. So maybe they're seeing a cardiologist, maybe they have chronic kidney disease, so they're seeing a nephrologist. If they have diabetes, they might be seeing an endocrinologist. And so how can we, what we call streamline the medication? So how can we make sure that there is continuous, it's continuous and it's simplified for the patient. Pharmacists will review the following in medication reconciliation appointments. So when I am in an outpatient setting, I oftentimes see patients who are on 5+ medications. And so when we look at this, we're looking at which drug are they on? What are they being used for? Are these doses according to the age, kidney, liver function, and other critical lab values? The frequency, and then the use according to current guidelines. And so I did want to distinguish this. I see in the chat that like in terms of outpatient and hospital, it can be really, really different. And outpatient is what I focus in on. And so the slides are specifically for outpatient. Hospital is mostly, at least in the US, we see a lot of transitions of care pharmacists. And so they help streamline that. And then there's also specific clinical pharmacists on what we call each ward. So if they're in the pediatrics, then they might be focusing on pediatrics. So the streamlining of medication reconciliation in a hospital is extremely different than outpatient. Okay, so these are kind of some questions that you want to go into when you're in a clinic setting. Is there duplicate therapy? And this is also specifically for hospital, right? When we're looking at a patient's log of medications, are we seeing that this patient is on 2 beta blockers? And if they're on 2 beta blockers, why are they on it? They probably don't need to be on 2 beta blockers, because what ends up happening is we have to look at their heart rate, for example, and is their heart rate going down? And I actually have seen a patient even on 1 beta blocker and their heart rate is low. And so duplicate therapy can also be in part to do with making sure that their lab values are not coming across as extreme. We also look at drug-to-drug interactions. So is one medication interacting with another drug? Meaning, is it decreasing the effectiveness of one medication over the other? And that can reduce the effectiveness, meaning that it's not providing the therapeutic goal. How many specialists is this patient seeing? So as I mentioned earlier, if in an outpatient clinic, a patient is seeing multiple specialists, the specialist might not know what medication this person is on. So the cardiologist might think this patient is only on an ACE inhibitor, while they might actually be on like a beta blocker. And so maybe the streamlining between specialists is not consistent. And so we have to ensure that every specialist knows what the patient might be on. So if the cardiologist doesn't know that the patient is on a beta blocker, and nor does the endocrinologist, a beta blocker can actually mask the hypoglycemic events of a patient if they have type 2 diabetes. So say the endocrinologist doesn't know either, that can actually affect how we're approaching the patient's diabetes. We also want to look at declining or reduced function of the kidneys or the liver. This is really, really important. Those who work in the hospital, those who work in outpatient settings, how are their kidneys looking? How is their eGFR? If their eGFR is reducing, then we need to make sure that the dose of the medication is appropriate. And the reason we want to do that is so that there's no adverse reaction. So if it's not metabolizing correctly, or if it's not excreting correctly, that is, then it oftentimes can build up in the system and cause adverse drug reactions. Is this patient adhering to their medications? If they're not adhering to the medications, then that will obviously change the lab values. And is this patient taking any herbals or supplements or vitamins? So if the patient is on, for example, I'm not sure in Pakistan if they have what we call continuous glucose monitor. It's called a CGM. And it's something that is attached to those who have diabetes, and it reads the glucose of the patient continuously. So it's called a continuous glucose monitor. And if a patient is on a high dose vitamin C, so we're thinking, I believe it's 1,000 milligrams and above, if that patient is taking vitamin C, that will actually change the readings of the continuous glucose monitor. And so it's really, really important to ask if this patient is taking any herbals, any supplements or vitamins, because they can interact with medications, and they can also interact with something like a glucose monitor as well. And so we want to ensure that we have the full picture when we're looking at medication reconciliation. So now I'm going to get into a case application. And this is a very basic case. And the reason I'm showing this one, and this is specifically for outpatient clinics. I do not have experience in hospitals, so I couldn't give you a hospital case. But I will go into an outpatient setting, and you will see the complexity of how difficult it might be to understand how to approach this patient. So AM is a 70-year-old female who comes to your outpatient clinic today. Today's date is 7/27, and she comes in with a bag of medications. She has a long-standing history of uncontrolled hypertension, hyperlipidemia, and type 2 diabetes mellitus. Today's blood pressure reads as 139/88. And so you open the bag and you see the following. You see metoprolol, ER, 50 milligrams, 2 times a day. Insulin glargine, 30 units under the skin every day at bedtime. Metformin, extended release, 500 milligrams, 2 times a day. Lisinopril, 40 milligrams, 2 times a day. And atorvastatin, 10 milligrams, once a day. Okay, so I will explain my patient appointments like this. So when a patient is scheduled with me at the clinic, I actually do a pre-workup. So a pre-workup is before the appointment. And so what we're looking at with a pre-workup is the age, the family history, social history, surgical history, drug allergies, and the relevant lab work to each medication. So for example, if a patient is on metformin XR and they have been on this for a long time, we want to make sure that we're checking their eGFR, because there is a cutoff for metformin with the eGFR, and it's actually at 30, and you technically should not initiate it at 45. And the reason for that is because it can actually cause lactic acidosis. And so we want to ensure that we're not promoting anything where it's not excreting properly. And so oftentimes I see a lot of patients on metformin. And so I have to keep track of their eGFR. So if it's been more than 6 months and I feel like I need to check it again, I will have a medical assistant come and draw the lab, and I will check their eGFR and see if I need to adjust the medication. And for example, another example would be lisinopril. And so I want to look at their blood pressure. So when the patient comes in, and in this case, the patient's blood pressure is 139/88, which according to the American Diabetes Association, that is not at goal for a patient who is diabetic. So the goal is to be less than 130/80. And so if I'm looking at lisinopril and I'm looking at whether or not it's helping, it may not be helping. And I don't know that, of course, right? I don't know if the patient is taking the medication. I don't know if there's some kind of another issue related to the medication that I need to address as to why the patient might not be taking it. So when I'm looking at lisinopril, I have to check their blood pressure. So before I go into the appointment, I'm looking at, okay, their blood pressure is elevated. They're on a blood pressure medication. Are they even taking the blood pressure medication? That's the first question. And then the other thing that I want to look at is, do we have a BMP or a CMP to check their potassium level? So ACE inhibitors and ARBs oftentimes can elevate the potassium level, right? And so if it does, then we want to make sure that we are adjusting the medication or stopping the medication when we need to. So if the person has reduced kidney function, it might mean that the patient might have increased levels of potassium. Another example would be metoprolol. So metoprolol can affect both blood pressure and heart rate. So we also want to ensure that we're looking at the blood pressure and then making sure that the heart rate is not decreasing. I have seen this where a patient was on metoprolol and their heart rate was pretty low. And I made a suggestion to the doctor and I said, the heart rate is low. I think we should see if this patient is, one, taking their medication. Is it due to something else or is it because of the medication? And then if the patient is taking the medication might actually be too strong for them. So we have to adjust the medication. So I know this is kind of a lot, and I know I'm talking quite a bit and it can be a little confusing, but this actually provides some information on what you want to do before you go into the appointment. So you're looking at their age. If they're older, then we want to make sure that they're not on any medication that might harm them. Family history. This makes a difference because if a patient has a family history of high cholesterol or high triglycerides, and we're noticing that the patient's triglycerides are trending upward, maybe this is a familial triglyceride problem, correct? And so we want to ensure that we're keeping tabs on their family history. Social history, meaning if they're smoking cigarettes actually changes the way that you metabolize medications. And so if the patient is smoking continuously, which oftentimes I see in Pakistan, many individuals smoke. So if they're smoking, they might not be actually processing the medication in the body appropriately. So it could mean that they're metabolizing it like poorly, or they might be metabolizing it too quickly, and it depends on the medication. Surgical history. So if a patient had a gastric bypass, for example, and a patient is on a what we call a GLP-1 agonist, and they're on an injectable GLP-1 agonist, we want to make sure that the patient is still eating, because a GLP-1 receptor agonist focuses on the hunger of the patient. And so it reduces how much they feel or how often they feel hungry. And so we want to make sure that if the patient had gastric bypass and they're on an appetite, I guess, like a reduced appetite regimen, then they might end up losing necessary nutrients. And so the surgical history is really, really important as well. Drug allergies, of course, we all know what the importance of that is. So I don't think I need to touch base on that. So this is a lot to do before an appointment, but you get used to it. Once you get more practice in it, you kind of get used to it and start to understand what you're looking for. So now you get into the appointment and now you're having this conversation with this patient. So why are they on this medication? So I go into the appointment as a pharmacist and I have this conversation with them. So I'm looking at, okay, they're on this medication because of, their blood pressure, their cholesterol, and their diabetes. And so I'm able to categorize these medications. And so that's actually usually what I do before I go into my appointments is, okay, why are they on this medication? Do they actually have to be on this medication? So if I'm looking at this case, lisinopril is fine for hypertension, but for the metoprolol is used for, it's actually used as a last line therapy for hypertension usually. And so what I initially think of is, okay, ACE inhibitor is fine, which is the lisinopril. But why are they on metoprolol? Why did we not try hydrochlorothiazide? So why did we not try a thiazide diuretic or a calcium channel blocker? Because according to American Heart Association, this is usually what we're looking for. We utilize beta blockers as last line therapy. So that's the first thing that comes to my head. Now with cholesterol, they're on the atorvastatin, which is great. And then for type 2 diabetes, they're on metformin and then insulin. So now the second step that I'm looking at is, are these doses appropriate? What are the maximum and minimums of each? So if I look at lisinopryl's maximum is actually 40 milligrams a day, but the doctor wrote it as 40 milligrams 2 times a day. So this is incorrect. And as we discussed before, if the patient has reduced kidney function and if they have reduced kidney function and they're on an ACE inhibitor or an ARB, then this can impact the potassium level. It can elevate the potassium, which can create a problem, correct? And so that's the first thing that we would want to correct. The metoprolol, 50 milligrams 2 times a day, there's technically no maximum dose, but the initial dose for hypertension is 50 milligrams 2 times a day, which is good, right? In the context of this, it is fine with the dose being correct, but in terms of the guidelines that AHA has provided, it may not actually follow that. And then the next one is atorvastatin, which it is for 10 milligrams once a day, and the maximum is 80 milligrams a day. So we are good on that. Metformin, we have them on 500 milligrams once a day, and the clinical maximum is 2,000 milligrams a day. You can actually prescribe metformin as 2,500 milligrams, but the clinical maximum is 2,000, meaning after 2,000 milligrams, it may not actually help reduce the A1C. And so this is where the benefits versus risks ratio comes. So if someone is put on 2,500 milligrams a day, that might actually cause them to have lactic acidosis for no reason. So we try not to go above the clinical maximum dose. For insulin glargine, we have them on 30 units at bedtime, and there's really no maximum dose for insulin. Usually we'll start patients on 10 units, and then see how they're doing depending on where their glucose levels are at. So this is kind of where you want to look at the doses and see if they're appropriate. Is this therapy appropriate according to current guidelines? And so this is what I was discussing about the metoprolol. So for the metoprolol, AHA recommends that this is the 4th or last line therapy of hypertension. So could there be a misdiagnosis? That's the first thing that I think of. So do they have heart failure and we just don't know, and they're on metoprolol succinate for heart failure? And I might not have that information as a pharmacist. Maybe the cardiologist knows, which is a specialist, but I don't have that information. And so that's why it's really, really important to be in contact with a specialist and ensure that you have correct documentation, because I am assuming that this patient is on metoprolol for hypertension, but they might actually have another condition that it's being used for, like angina or for heart failure. I forgot to type in the cholesterol one, but according to AHA, we can start this patient on 10 milligrams, but the ideal dose would be 20. And that's because it also depends on her age. So her being 70 years old can be an indication that we're unsure if we want to put her on a high dose statin medication to reduce her cholesterols. And we would also have to know her cholesterol levels. So what's her total cholesterol? What is her HDL? What is her LDL? And how low do we want to get that LDL? Usually we're looking at less than or equal to 70. And so we want to see if the dose is appropriate for that according to American Heart Association. The next one is ADA guidelines. And ADA guidelines now recommends to use a GLP-1 receptor agonist or an SGLT2 inhibitor. Now, this is where your independence comes up as an important factor. So would you consider this to be incorrect? And If I were in this appointment, I would keep this patient on metformin as long as their EGFR is correct. And the reason I say that is because metformin has a very, very good tolerance level. I think maybe some of you know that metformin has side effects such as diarrhea, and it is really, really uncomfortable for patients. And so that's why we usually put them on the extended release formulation. And so that's really the only side effect that I'm concerned about. I'm also concerned about their kidney function. And if everything is good, then I would keep this patient on metformin. The A1C reduction on metformin is between 1 to 2%. If they are adhering to their medication appropriately, and if it is maximized to 2,000 milligrams, as we showed earlier. Some people choose to start the patient on a GLP-1 receptor agonist or an SGLT2 inhibitor. And it truly depends. It is a patient-to-patient scenario. And for example, if we want to protect their kidney, or if they have CKD, chronic kidney disease, then maybe we want to put them on an SGLT2 inhibitor. And I don't have it in these slides, but if you look at American Diabetes Association and their research on SGLT2 inhibitors and its role in chronic kidney disease, it actually has really positive outcomes. And so we want to make sure that we're being patient-specific. So patient-centered care is the base foundation of clinical pharmacy. The last one would be insulin glargine. So insulin glargine right now, or insulin in general, under ADA guidelines for a type 2 diabetic, is that it is a last line therapy. And there are many reasons for that. And it's in part to do with, back in the day, insulin was known to be, an amazing medication and provide so much help. And it really does. For a type 1 diabetic, it's obviously we have to give the insulin. But for the case of benefits versus risks, we're beginning to see newer therapies helping with cardiovascular and renoprotective effects. So GLP-1 receptor agonists and SGLT2 inhibitors have cardioprotective and renoprotective effects. And so really the base of these appointments, I know it's a lot, but the base of these appointments are really up to what you feel like through your research with guidelines, using evidence-based medication. What is the most appropriate to put this patient on? So the question I have is, what changes would you recommend today? And I know it is a lot. When you look at this patient, you're thinking, okay, I need more information. If this were my patient, I would probably take off the insulin glargine, and I would actually add them on another medication, such as a GLP-1 receptor agonist or an SGLT2 inhibitor, and I would take them off the insulin. And the reason for that is because this patient is 70 years old and they are on insulin. Insulin is known to be a really high-risk medication, meaning that it can actually increase the number of falls in a patient who is above a certain age. So 60 to 65 years of age, we have to be very careful of what medications are on, because there are medications that can increase the risk of falls. And so insulin is one of them. And there's a higher chance that this patient might have reduced glucose levels. And so we want to make sure that we're not using a very strong diabetes medication that will bring them below goal, right? We're trying to keep their organ system balanced. And so that's one thing I would do. The next thing is I would tell the doctor that, okay, the lisinopril is the wrong frequency. It should be lisinopril 40 milligrams by mouth once a day. And then the atorvastatin, I would obviously need more information of their lipid panel and then their LFTs as well to see, okay, do I want to make any adjustments? This is a very basic case. And the reason I didn't give too much information is because it can be really overwhelming. So I want to ensure that you understand the base of clinical pharmacy. So this is literally the base of clinical pharmacy. And I know It can be a lot, but when you get used to it, you can better understand how to manage medications. And as a disclosure, not all pharmacists do the same thing. So your pharmacist colleague might have a totally different approach to this patient, but you might think of it differently. So it depends. So don't feel discouraged that clinical pharmacy is not something that you feel like you can do because you're doing it differently than another person. Okay. Let's go forward. So some additional pearls or additional questions that you want to ask. Is the patient adherent to the medications? If the patient is not adherent to the medications, then technically you have to encourage them to take the medication. If you make a change of a medication at the appointment, they still may not do anything about it. So there is no purpose of making a change to the medication list. How are they storing the medication? So I know in Pakistan, it is really hot year round. And in California, it's also hot very frequently. And if a patient is keeping their medications in their car, so I have patients over here who keep their medications in their car. And if it's hot outside, then it's obviously hot in the car. And so the effectiveness of every tablet can actually change if it's in the heat for a prolonged period of time. And so if they're keeping their medications in the car, then it might not actually help, meaning that if they're keeping their medications in the car and they're telling you, ARZU, I am taking my medications, but it's not working. Okay, well, let's talk about where you're storing your medications. Let's see why it's not working. Are you storing them in a proper area? So if they're storing it in heat, it's probably just a reduced effectiveness of the tablet. It's as simple as that. Sometimes it's the simple things in an appointment that can help you understand how to help the patient. When did they last refill the medication? This is an excellent way to check if they're actually adherent to the medication. So if you ask them, okay, when did you last pick it up? In the US, there's actually on the label of the bottle for the medication, it will tell you when it was last filled or the date that the medication was dispensed. And so sometimes I see some patients telling me, oh, I've been taking the medication. I barely miss it. And then I look at the date that it was dispensed and it was last year and it was for 30 days or 90 days, right? And so something as simple as this, you can understand that, okay, maybe the patient does not want to admit that they're not taking the medication. The other thing to keep in mind is it their actual medication? There are some patients over here who take other people's medications. So maybe their family member has hypertension too. And so they end up taking their blood pressure medication, but they bring it to your clinic and they say, yeah, I have been taking it. And they end up showing you a bottle of their family member. So I've seen stuff like that as well. Are there any other barriers to this patient that you have to keep in mind? So we're looking at accessibility. So do they have access to a clinic? Do they have access to a pharmacy? We're looking at housing. We're looking at socioeconomic status. Can they actually afford these medications? Are they having a hard time getting it? And we're looking at instability, life instability. Was this person in jail? Was this person in a gun shooting? Very simple things that can really distress a patient and can cause a different approach in an appointment. We're looking at social history. So I mentioned how smoking cigarettes can change the way that you respond to certain medications. And so that's something to keep in mind as well. So these are some organizations and websites to use for updates. You can look at American Pharmacists Association, ASHP, ACCP, IDSA. I know infectious disease is a really, really common topic in Pakistan and in the hospital setting over there. And so looking at IDSA and keeping up to date with their guidelines is really, really important. I love IDSA. I think they have very great guidelines. I think they recently actually updated something regarding urinary tract infections. K2Go is actually for kidneys. So I use that guideline frequently for those who have chronic kidney disease. You might look at AAFP, which is the American Academy of Family Physicians. FDA actually provides just acceptance and approval of medications, not so much of guidance changes, but more so what are the updates on medications. And then LinkedIn. I also have LinkedIn, by the way, in case anyone would like to connect with me. But LinkedIn is a great opportunity to connect with other pharmacists. And there are pharmacists who actually update guidelines, or they will post about updated guidelines, and share like APHA or ASHP or ACCP. And these will like kind of help you stay up to date. I know social media is a big thing. We're not good about getting membership for these organizations. It can be really expensive. And so I think it's important to kind of keep in track of who can actually help. I don't know if Pharmacozyme helps with providing updates to guidelines, but it might be something that can be looked into for the future as well. And then challenges in global settings to kind of wrap this entire thing up. In global settings, so we're looking at everywhere, by the way. This is like even in the US, it can happen where, we don't have enough medical doctors in certain areas. There is a lack of pharmacy schools, meaning that there are not enough pharmacists available. Inability to practice at a clinical level. So I know in Pakistan, there aren't really any outpatient settings where you can actually help to provide your services. And so this is actually what MedMadad is aiming to do. We are trying to provide clinical practices for pharmacists in areas that are oftentimes neglected. And so that's kind of what we're trying to get through with MedMadad. And I hope to bring it to Karachi. I hope to bring it to other places in Pakistan where we are trying to streamline the process in Sakha right now. And I hope to continue with Pharmacozyme and figure out how we can provide certain clinical practices that will help you better understand how pharmacists can really improve a patient's longevity. And then populations of rural backgrounds are often neglected, as I mentioned. And then the lack of quality control, which can lead to substandard and falsified medications as well. There's a preference for Eastern medication in certain areas. I know that I love Eastern medication. I think that holistic approaches are really, really good. But, it's also important to keep in mind that Western medication can also help to an extent as well. So key points. Clinical pharmacy appointments often take multiple visits to bring the patient to goal. I have seen one patient about 5 times in like 2 months. And it's because it's so much information to take in one appointment. And sometimes it takes multiple visits to get them to goal. Pharmacists will sometimes coincide with other healthcare providers with regards to medications. So remember that doctors work differently than pharmacists, and that's totally okay. We have a different understanding of medications compared to them. And so you want to make sure that you standardize in the clinic, in the hospital, how we want to approach this. And it's really important for every hospital and every outpatient setting to have a pharmacist on board, because we look at medications really, really differently compared to another healthcare professional. No appointment will be the same over a blanket of patients. So you have to keep in mind that patient-centered care is really important. So every patient will be different. One patient will have an amazing EGFR. It might be above 120, but another patient might have an EGFR of 25, which I do often see. I see a lot of patients on decreased kidney function. So we want to make sure that we're making sure we're looking at every lab value to ensure that the medications are optimized. It's also important to stay informed of any guideline changes, as I mentioned. So this is where we open up to questions, and I will let our Pharmacozyme board figure out how we want to do this. I know I missed some of the questions in the chat, but I hope to help in any way.
Now let's move to the question answer session. We have received some great questions from our audience. So I'm just asking you one by one quickly, so we will wind up this session.
Sure.
First question we have from Rumesa Faruqi. Apart from our primary degree, that is Doctor of Pharmacy, are there any additional specializations or specific knowledge areas required to pursue career in specialized fields such as oncology or cardiology as a pharmacist?
Yeah, absolutely. So Well, this might be something I will have to look up for you, but BPS, they do board certifications. And you can get board certified in ambulatory care, in infectious diseases. I know in Dubai, they are able to do board certification. I don't know if you can sit for it in Pakistan. So I will check that. Excuse me, can I put it in the chat? Maybe I can copy and paste the link. Is that possible? Let me see.
No, ma'am. I think it's not possible for us.
Okay, no worries. I can maybe email it to you all, and then I can, and then we can see if in Pakistan you are able to sit for board certification.
Yes, sure. I will share.
Let's move toward another question.
Sure.
When there's a potential drug-drug interaction, but both drugs are clinically necessary, how do you manage the therapy?
That is a really good question to whoever asked it. That is difficult, and it depends on the scenario with the drug-to-drug interaction. A lot of the times, I think it's a benefits versus risks situation, and so you have to understand maybe you might need to reduce the dose of a medication. So I know in the US, warfarin is still used, but warfarin isn't frequently used anymore. And if there's a drug-to-drug interaction with warfarin, oftentimes we have to adjust the dose of one of the medications. So you might have to decrease the dose of one of the medications. And in the context of it being clinically effective, if, for example, one drug increases drug 2 in the body, you would need a lower dose, correct? Because it's already accumulating in the body. So if drug 1 prevents drug 2 from excreting, then you can decrease the dose of drug 2. And so that's kind of how I look at it. It's a really difficult thing to manage, but the important part on this is to make sure that one, the patient adheres to the medication, and that when you reduce the dose, the patient understands to reduce the dose. So I actually see a lot of patients who do not speak English over here. They speak Spanish. And so I use a translator. And so to use the translator, you have to ensure the translator is also telling the person the right thing. So there are a lot of things that you have to keep in mind when there's a drug-to-drug interaction. Does the patient understand why you are reducing the dose? Will they be able to get the medication from the pharmacy? And then you will have to follow up with the patient. So following up with the patient to make sure that they're taking the new dose, and then looking at the lab values to make sure that that it's not harming the patient. So that's a very worded answer, but hopefully that kind of helps.
We have third question from Rumesa Faruqi.
Sure.
How does clinical pharmacy differ from hospital pharmacy in terms of roles, responsibilities, and scope of practice?
Yeah, that's a good question. So I am not very familiar with the hospital. I actually do not like the hospital when it comes to pharmacy. So it's a very, very different, it's a different role and responsibility. And it depends. So I've been to Al Khan, and I think Al Khan's hospital works a little differently. But I think they have clinical pharmacists. So I've seen in different wards at Al Khan that they, I think like there's like, pharmacists who work on pediatrics specifically, for example. So your focus then would be on pediatric pharmacy. So you would adjust the dose for pediatrics. You would adjust the dose for kids. And that's a very different streamline. And you can actually, I think, get board certified in pediatric pharmacy as well. So that is a little different. And then in an outpatient setting, you're usually working with a lot of adults. You might work with some, younger adults, depending if they have a very particular situation. So, for example, for HIV, I don't know in Pakistan if they have pre-exposure prophylaxis. I don't feel like I have heard anything about it. But I work with younger adults, so in their 20s, to initiate pre-exposure prophylaxis for HIV. So the setting is very different. Hospital, you'll see pediatric pharmacists, infectious disease pharmacists, antimicrobial stewardship. And then in an outpatient setting, you can do antimicrobial stewardship, but it won't be as extensive. You'll see more chronic conditions. So asthma, hypertension, osteoporosis, trying to think, gout. You might see things like that. So I hope that kind of helps. Like, I'm not too familiar with hospital, so I don't like to say the wrong thing. I can do more research if you would like to reach out to me, and I can give you a bit more details about it.
Okay. We have question from Sami. I do not have a question to ask, but would you like to shed light on how can pharmacists from Pakistan make their way into the US?
That's a good question. I assumed I would get a question like that. That is so hard. It is so hard. The political environment right now is really tough. So I think initially you have to get a visa. So you have to be able to get into the country first. And then you have to take multiple exams. So I think it's the equivalency exam. It's the FPGEE exam. And in order to take that exam, you have to be in the country. So it's like a really weird concept. I mean, I don't know why they did that, because honestly, when I was in Sakhar, I told pharmacy students in Sakhar this, that I think pharmacists in Pakistan are so smart, so intellectual. Like, I have seen like amazing drive from you guys, and I really, really appreciate that. Like, I mean, you all work so hard, harder than us. I have to admit to that. And so you have the ability to do it, but getting into the country is like, I don't know, it's like different depending on the person. So the first exam that you would have to take is the equivalency exam. And in order to do that, you have to get into the country, which I have no idea about the visa. So.
Okay. Okay, we have question from Rafia Sheikh.
Sure.
How can I start preparing myself for a future role in clinical pharmacy, especially when we haven't started hospital rotations yet?
That's a good question. So I think maybe, subscribing to Pharmacozyme would be one. I think that might help to kind of get you to understand clinical pharmacy. And, you know, if it helps the students, I can always do a webinar each month to help provide some basis of clinical pharmacy and how to approach it even before hospital. I can also help like work with people individually. So if you want to reach out to me individually, I can send you some references. I can send you some, I don't know, I've seen some on Instagram. I've seen some, things that can help you clinically. There is a book that helps, but it's really expensive, and I don't know if it's worth purchasing, but I can provide more information if that person wants to reach out to me through email or on LinkedIn. Then I can help work with people too if they have any questions with regards to clinical.
Okay. Now we have a question from Neha. What is the most challenging type of patient you have had to deal with, and how did you manage the situation?
Oh, that's an interesting question. Okay. So I work with a lot of patients who don't speak English. So that's one challenging thing. There is a patient who I have seen, I think I mentioned I have seen a patient like 5 times, and it's because the patient is just not interested in their health. So they come to the clinic, I see the patient, I say, have you been taking this medication like how I asked you last time? No, I haven't. Okay, why not? Oh, my job. Because my job is really demanding. I forget. And, he has decreased kidney function. His job is really hard. I mean, he works really, really hard. So he's just tired. And so motivating patients, I try to do as much as I can. I don't know if you can hear, but I have a lot of energy. So I try to do the same for my patients. I would say that in general, my patients are usually very complex. They're on multiple medications. It's not just one patient, it's a lot of them. And it's because pharmacists are not involved in certain workplaces. And so that can differentiate how patient care is. So that one patient, it's because he's not interested in his health usually. And so I have to kind of motivate him and provide him like, smiles and laughs and things. And, really encourage him. He does come to his appointments, so that is good. But I hope that kind of helps.
We have a question from Rumesa Faruqi. In US, who prescribe the drugs to patients usually? By the physicians, medical doctors, or by pharmacists?
Yeah, so it's actually usually done by physicians. It's not done by pharmacists. Pharmacists usually manage the medications. But in the state of California, there is a certification that you can get. It's called an advanced practice pharmacist license. And you can actually prescribe medication. The problem is that we have an insurance based healthcare system, unfortunately. And so some insurances, when we bill them, they do not accept pharmacists as providers. So that's another problem. So pharmacists can, but in specific states, but usually they just initiate the medication. They do not prescribe it. So they will tell the doctor that I am initiating. So for example, the patients that I will see for pre-exposure prophylaxis for HIV, I will initiate Truvada, which is an antiretroviral drug, and I will initiate it and then tell the doctor that this is what we need to do. So under the physician, I am being able to, I can initiate it, but they have to prescribe it.
Okay. So we have question from Rafia Sheikh. What soft skills are important for clinical pharmacists in addition to technical knowledge?
You have to have a lot of empathy. You have to have a lot of patience. If you don't have patience, don't do clinical pharmacy. And you have to have a lot of empathy and understand that people's lives are not all the same. Being in the U.S., it doesn't mean that you have money. There are a lot of patients who unfortunately do not have socioeconomic stability. So we oftentimes see them struggling in their day-to-day. They don't have enough money for food. They don't have enough money to purchase the medications. They don't even have a car. And so we actually at the clinic, we provide them transportation to get to the pharmacy. And so I would say that the two main things are patience and empathy, knowing that these patients are human by the end of the day. And you have to understand that no person's life is the same. I am a big believer in that. I believe in, really standing with people and understanding their life to ensure that their health is really good. So those are the two main things I'd say.
Okay, I think we have done all the questions.
Sure.
And now it's time to test your learning. We are launching the quiz in just a moment. We will be having quiz on Kahoot. You can add the provided code which is shared in the group. So do join from the group. We will be waiting for a few minutes for the participants to join Kahoot. We are going to start within 2 minutes. We are waiting for participants. Three, two, one, and let's start. What is the core focus of clinical pharmacy? What is the core focus of clinical pharmacy? And the answer is care. Scoreboard we have Sidra Usman, Hafsa Khan, Hiba Khan, Anabia Imran, and Samiullah. Next question: which class of drugs does AHA recommend as first-line therapy for hypertension? We have beta blockers, calcium channel blockers, ACEIs, and diuretics. Which class of drugs does AHA recommend as first-line therapy for hypertension? And the answer is ACEIs. Sidra Usman is our top scorer. Next, we have which organization provides drug safety updates in the US? WHO, AAFP, FDA, KDIGO. Which organization provides drug safety updates in the US? 5, 4, 3, 2, 1. And the answer is FDA, Food and Drug Administration, FDA. Okay, so Sidra Usman is our top scorer and Samiullah and Sajid. Rumesa Hiba Khan, guys, you are doing well. Which metric is improved by pharmacist-led interventions for diabetes? Which metric is improved by pharmacist-led interventions for diabetes? We have HDL, LDL, A1C, and TSH. 19 students have answered, and the answer is A1C. It's A1C. Sidra Usman, Samiullah, Sajid, Hiba Khan, and Sidra. Next, what is the maximum recommended daily dose of metformin XR? Maximum recommended daily dose of metformin XR: 1000 mg, 2000 mg, 1500 mg, and 2500 mg. Which option is best? Maximum recommended daily dose of metformin XR. Medication reconciliation focuses on reviewing what? Drugs, labs, cost, or lifestyle. Which one is the best option? We have received 10 answers. Let's see who is correct, who is giving correct answer. Now 20 answers, and the best is Sidra Osman. What is the role of clinical pharmacist in hospitals called? Role of clinical pharmacist in hospitals called? Community, inpatient, ambulatory, or retail? Most easiest question. What is the role of clinical pharmacist in patient? That's good. So we have Eman Ali, Sidra, and Sidra Osman. These are three top scorers. Which guideline body is associated with kidney disease management? Which guideline body is associated with kidney disease management? Which guideline body is associated with kidney disease management? The answer is KDIGO. Rumesa is back in the game. Wow. Which condition is treated with atorvastatin? Diabetes, infection, hypertension, or hyperlipidemia? What will be the correct answer for this? Let's see. Samula is making a comeback with 3 in a row. Next question. Which social platform was mentioned for professional updates? LinkedIn, Twitter, Instagram, and Facebook. The most easiest question of this quiz. Which social platform was mentioned for professional updates? Yes, obviously, LinkedIn. LinkedIn now.